you will miss cases, you will mistreat, and you will really be a bad doctor if you look at weight as the first issue.
Dr. Alexandra Sowa, how are you doing, my friend?
I'm well. Thanks for having me.
I'm excited to chat with you again and hear all of the amazing things that you're up to and hopefully shed some light on obesity medicine for the premeds and medical students that are joining us here tonight. The one question that I've been loving and the students have loved is, what is bread and butter for obesity medicine?
Bread and butter would be anyone that needs to lose weight for their overall health. And so we help them achieve that, because traditionally in medical school, especially when I was in training, you just told people to eat less, exercise more, good luck. We'll see you in 12 months. And all of their metrics would get worse. They would get discouraged. They might not even come back into your office. And so our bread and butter is just helping them with actual solutions that are based in evidence and science.
What are some misconceptions around weight loss that students that are coming up through the system now? Unfortunately, we don't get a lot of nutrition teaching and learning in medical school, but I think the common wisdom is diet and exercise, eat less, you'll lose weight. What do they need to learn right now to hopefully get off of that mindset?
So two things. So that is not the case. So when you are a normal weight and you're metabolically healthy, eat less, exercise more, and energy balance, it works. What happens is when that energy balance gets disrupted and you become metabolically unhealthy, which is often the case when there's excess weight, and people think they know that they need to lose weight, but what they don't understand is that there's usually a metabolic issue underlying that weight gain and inability to lose weight. So once that already happens, it's not as easy as telling someone just eat more vegetables. Now, sometimes it is. Sometimes you can really make an impact just with diet alone. But it's not just eat less, because we have a biology that does not want us to eat less. So you just put someone on a calorie restricted diet and it's really, really hard to stick to. So that's rule number one, is that weight. And the thing number two that kind of goes along with that is that excess weight is not a sign that you lack willpower, right? There are a lot of very intelligent, driven, hardworking people who suffer with weight. There are a lot of doctors who suffer with weight, right? And it has nothing to do with willing it away. And so we often, and in medicine, and this leads us to the third point, is that there is a significant weight bias in medicine. Break that now, okay? You will miss cases, you will mistreat, and you will really be a bad doctor if you look at weight as the first issue. So many studies show that because doctors aren't comfortable in having this discussion with people and they themselves don't feel empowered to lose weight, they often don't ever have the conversation, and they don't actually look for the underlying issue of what someone brought someone into the office. Instead, they just say, go lose weight and come back to me, right? Yeah. But we already talked about how in point number one, it's not that easy. So you will never establish a good relationship if you lead with weight. So, and work really hard against that bias.
Yeah. Patient comes in with knee pain who technically is obese or even morbidly obese, and you shrug it off and go, lose weight, your knee pain will go away, and you miss the underlying bone cancer that's been growing for a while.
Exactly.
Yeah. That's an issue that we hear all the time. The path to become an obesity medicine physician, because a lot of students here are probably hearing this for the first time, going, wait, internal medicine, pediatrics, general surgery, orthopedics, neurosurgery, there's no obesity medicine. Where did this come from?
Yeah.
How do you get there?
So it is an awesome, small but mighty and growing field that has really evolved as the science and our understanding of what obesity is. And let me kind of back up a second. Obesity is a disease. It is defined as such by the World Health Organization, by every large health organization. It is a disease. Insurance is lagging in recognizing it as a disease, and workplaces are lagging in recognizing it as a disease, but it is, right? So as we started to realize all of the multi elements that went into this, so it's environmental, It is lifestyle, it's genetics, it's epigenetics, it's exposures, it's viral. It's so much more than we can understand. But we realized that we really needed a field to address this. And so over the past 15 years, as the science has been evolving, so has our ability to treat. The American Board of Obesity Medicine was born, I think, a little over 10 years ago, and started offering board certification in this field. Now, it is not a fellowship track at the moment, but there are emerging fellowships. So you have to do a primary training first. So actually, you can come and sit for these boards in any specialty. You can come from any walk of life as long as you had completed your residency. And you have to sit for qualifying hours and exams and in-person and tests before you're eligible. And it's more of a hands-on life experience than potentially other kind of fellowships that are more academic based. But there are wonderful fellowships that are popping up every year more and more. And it really wasn't even around when I was entering in to the field. So I would encourage you to check those out. And even if you're looking now and you think this specialty sounds exciting to you, like, look at the schools that have these and talk about it on your interview track, because we need more doctors, like, want to attract. And every year this field is growing and growing and growing. Because to be honest, our problem is growing and growing and growing.
Unintended?
Yeah.
Yes. I like nerding out, and I know leptin research is getting very close to figuring out how to shut off this pathway. How close do you think we are from taking a pill to where those who are obese, that the leptin that's constantly telling them they're hungry and all the other stuff that comes with it is kind of put away?
So we're very close. I mean, we're practically there. It's not just leptin though. So just for everyone at home. So, I'm a medical doctor. I'm not a surgeon, right? And before, we only had these surgical options. And surgery helps shut off those hormones, the hunger hormones, ghrelin, and leptin is the satiety hormone. But as you lose weight, it goes down. And by kind of balancing these hormones, we can help people achieve homeostasis, loss and then homeostasis. And surgery was one of those options. And surgery is still a great option. The field that I'm in is medical weight management. We're on the cusp of that. So there are 5 FDA approved medications for long-term use for weight loss. So another high level point. So tuck it away, everyone who's listening, that eventually when you're able to write prescriptions, remember this. We have them. They're underutilized. Most doctors are scared of them, don't understand how to use them. They're very safe. They're effective. They're FDA approved. Some of these medications do interact and interfere really with these pathways that otherwise they go haywire, and all you do is have increased hunger and increased energy imbalance where your body has no idea how to burn it and just stores everything as fat. We starting to have these medications, and they are coming in the form of hormone mimickers. So some of the hormones in this crazy extensive pathway, if we can occupy and upregulate the hormones that block hunger, that block digestion, that or slow down, rather, you don't want to block it entirely, but you slow it down and you improve the way that energy is cycled, then you can have long-term success. And so we are seeing that. I think within our lifetimes, the other big thing that we'll see in this field is the emergence of better understanding of bacteria and viruses.
Microbiome.
The microbiome.
Yeah.
There's something bigger going on than just us eating more and more packaged foods, and moving less, and we've got better temperature control than we did, but something else is off, and it's likely our kind of exposures, and that even start in utero to the microbiome. So that is the big thing that I'm incredibly excited about.
Yeah. One of my best friends from medical school runs the celiac clinic at MGH in Boston, and all of her research is around the microbiome. She lives for poop bacteria. So it's awesome. That's her life. That's exciting. I'm excited for that, the role of medication in the future for this. Obviously, multiple potential angles to tackle this, potentially all of them needed to successfully help a patient. Talk about the psychology aspect of things. I know for me, my personal struggle with my weight is an addiction to sugar. My grandfather was an alcoholic. My mom potentially. My addiction comes in the form of sugar. And so like the other day, my wife makes cupcakes with the kids, and I'm like, oh great, now we have cupcakes in the house. And instead of eating one, I eat 5. Talk about the role of psychology and partnering with a good psychologist to help patients in this as well.
Okay, so I had a mentor once who was a surgeon and would tell patients, I can take out part of your stomach, but we can't take out part of your brain. So you got to work on the brain. And I thought that was such a smart way to think about this, because you cannot just use a medication. You cannot just put someone on a restrictive diet. You cannot just do one thing, cannot just exercise it all away. You must address the whole body. It's really, I feel like my little segment of medicine is the most holistic, meaning in the literal sense, top to bottom and inside and out, because you have to address what's going on up here. So we need to get to the root of what it is. So in this instance of like the being addicted to sugar, so your body's not going to stop functioning, but there is something that in your brain is telling you need more and more. And we need to kind of drill down into that. So it sounds like you've even done some of the, early work in this example of like, okay, there's some familial precedent. When I was a kid, did I get rewarded with food? Was this a behavior, that I learned and that I continued, and now we need to get into it. And kind of approaching food and our relationship to it from a cognitive behavioral therapy standpoint is very, very, very effective. A lot of patients also suffer from overweight and disordered eating who suffered emotional trauma as children. And
ACEs, do you deal with ACEs at all?
Yeah. Yes. And so we really need to touch it delicately, approach it and acknowledge it. And when we identify it, working with a therapist who's trained in understanding and reversing it and moving forward, dealing with the past, but then moving forward in this new kind of healthy venture can be really effective on that front. So talking about addiction. So food can be very, very addicting. And there is definitely a comorbidity between the brain and then what's going on in the metabolic health of the body. And there is a medication built just for that. It's called Contrave. And Contrave deals with the addiction center of the brain. It's used in other facets. So it helps people cut back on smoking with smoking cessation. And the second part of the drug, so the first part is Wellbutrin. The second part is naltrexone, which is used to help people cut back on alcohol. And it works on the pleasure receptors of the brain, and it decreases dopamine in response to certain foods. And it's a remarkable, remarkable medication. And it's not habit forming in the sense that while you're on it, it allows you to do the work to say, oh, I need to get to the root cause of why I turn to these foods in this addictive behavior. So we have medications that address that.
Ooh, that makes me excited because I've wanted to look into Wellbutrin for a while, because lots of like the fancy people in the tech world and everything take Wellbutrin now just preventively because it's supposed to be kind of lifelonging, whatever, good for you metabolically and everything.
It kind of levels things out in your brain.
Yeah.
So I don't just recommend taking that one. It does not have a ton of evidence for lifelong longevity, but for the right reasons, it's a very effective and safe medication.
I'll have to look into that. That's exciting. Talk about a bunch of people are asking about BMI. How do you define obesity? BMI, I think, has long had some issues with how it's measured. I typically have more muscle mass than a lot of other people. And so just by BMI standards, I'm obese, even if I feel like I'm at a healthy weight. How do you define obesity?
So this is something that took me a little bit of time to learn when I was right out of practice. I'll say right out of the gate. I remember having a patient when I was first attending in outpatient medicine who was like a bodybuilder. And his BMI was high. And I was so confused by it because you learn this as a screening tool and as a metric. And then my EMR was pinging. I'm like, what do I do about this? And then his creatinine was a little high, but it was because his muscle mass was so high. So it was like a little clinical pearl there. And he was totally healthy. So BMI is an inexact screening tool, and it really exists to just kind of quickly put people into buckets. Remember about what happens when you put people into buckets, though, without understanding the context, is that you assume a lot and you can miss a lot and you could over medicalize. So in that scenario, I could have over medicalized this guy, and he was like the healthiest patient I probably had in my panel at the time because his BMI was high. So it's just a screening tool. And I think it carries so much judgment for patients. You have to be very, very careful about how you approach it. Honestly, our EMRs do not tread delicately on this. People can sign into their portals. They'll see that their BMI is raging. They'll put it in red. And even if they've lost 50 pounds and their BMI is still high, that doesn't matter because they've made big improvements in their health and they've lost 5, 10, 15% of their total body weight, which is all I can ask for, but their BMI is still high.
Yeah.
So BMI is a relationship between height and weight. And there's actually not a difference for men or women, which is kind of bananas, right? So just think about that, how kind of inexact that is when we're talking about muscle mass. But technically, we do use it to define and to kind of screen people. So BMI is defined as a body mass index over 30. Overweight is between 25 and 29.9. That's a wide range, right? Medications are actually technically FDA approved, not just for obesity, but for a BMI of 27 or greater with a comorbidity. And that means something else that is negatively impacted by weight. So blood pressure, type 2 diabetes, metabolic syndrome, osteoarthritis, back pain, neck pain, things like that. So we use it, and it's kind of like a check box, but realize it doesn't mean everything. There are some much more subtle ways to pick up the ill effects of obesity. And what I would encourage everyone who's listening, again, just kind of like tuck it away for the future, is metabolic syndrome. So metabolic syndrome is a constellation of findings that take into account waist circumference, which is a more accurate tool about unhealthy weight. And it has a difference between men and women. So women have to have a smaller waist circumference and men larger. And it takes into account blood pressure, certain lipids, and your blood sugar. And looking at that, if you actually did that for every patient who came through, you probably screen a lot more disease than just looking at BMI.
Yeah. I just want to rewind for some students who heard me say ACEs earlier. You had mentioned things that happen in childhood. That's adverse childhood experiences. It's a kind of a survey that I don't know how long ago it was developed. It's still relatively new. And there's just huge correlation between trauma as a child in various forms and addiction and obesity and mental health issues later on. So hopefully as that gets more and more known, we can help these kids much earlier so they don't have any issues later on, or less issues later on. So I just wanted to rewind to that. So I want to talk to you when a patient comes to you. Let's try to do a little mini case here. When a patient comes to you and says, "Dr. Sowa, I am obese. I don't like the way I look. I don't like the way I feel. My blood pressure's high. The doctor says I have type 2 diabetes. I try to eat salads. I try to go for walks, and the weight just doesn't go anywhere." What are the kind of steps for you in terms of trying to figure out what's going on?
First of all, I validate them. I tell them that I hear them and I believe them, because most people who are at that point of saying, I really try, most doctors have said, I don't believe you. Yeah. Okay. And that's incredibly devastating to hear as a patient. So first you validate, and then you start to do your investigation. And this is what I really love about being a physician in this field that makes us very different than other wellness and medical providers, is that we can really dig deep. So I'll take a good history. So like every medical profession starts there. It's just, tell me about it. Give me your weight history. Talk to me about and they'll say, well, how far back? Let's start from the beginning. So I actually ask people to plot out their weight and their loss from childhood onward. And it's a very different workup if someone's weight has just happened in the past 3 months and is very, very dramatic, versus someone who's been a slow creep, versus someone who's gone up and down and up and down and up and down their whole lives and has been what we call, a yo-yo or a cyclical dieter. So you can garner a lot from just words. And then we get a good medical history on them, good surgical history, and then a good medication history on them. So a lot of what other doctors use, or even over-the-counter supplements, can lead to weight gain. And unfortunately, I don't think it's part of the education and the conversation about starting many medications that can put on a lot of weight. And so we start there. And then we move on to the physical. And I'll tell you, in times of COVID, my practice has transitioned entirely online. So as long as someone has had a physical within the last year, I can accept it. So we're actually doing a lot of just tell me about it, or stand up and show me in the camera. We're looking at for a few things that other doctors might miss, but we do kind of do head to toe, good thyroid exam, a good oral exam, looking for. I wonder if anyone out there could think about what I want to see on the inside. It's not your tongue. It's the back of your mouth, and to see if you're high risk for sleep apnea, which is a big contributor to weight gain, and kind of go all the way down. And on the belly, I specifically look for things called stria, or they're like thick stretch marks. So not just stretch marks that normally appear, but kind of thicker, and they're pathologic for other issues. And most of the time you don't find anything, right? It's a little bit more subtle than that. So what do we move on to? Move on to labs. And I'm very particular about the kind of labs that I order, and they're not outside of the box. I just look at them differently. And one of the things that we really, really look for in metabolic and obesity medicine is insulin resistance, and subtle insulin resistance, because that's often the first sign that when someone says, I'm doing everything and I cannot lose weight, is that the way that we traditionally learned in medicine was to only kind of really approach prediabetes as it was like care about it, as it was like getting towards type 2 diabetes. But there's many, many years of insulin resistance build up to that. Yeah. And so if we identify that, that's kind of one of the things that we'll focus on in our approach. And then what do I do? And then I get everyone to keep a food log. So this is really important for my practice. So it's so hard. Recall is so hard. Dietary recall is impossible. But just like anything in life, you can't remember what you wore 2 days ago. You can't remember what you ate 2 days ago. So I give everyone a food log that they have to keep in real time. And I gather a lot of data from that. And not only do they log their food, but they tell me how they felt about it. And interestingly, in my practice, I don't count calories. So we don't do it in the traditional apps like MyFitnessPal, or the ones that are kind of complicated that people are like, I can't find exactly what I ate, so I didn't write it down. And then I got frustrated, so I never went back to it. So we actually just keep an old school log, and they'll tell me how they felt. Like, I was bored, my family was eating, so I felt like I had to eat. I was really ravenous, or I didn't like this meal, because you can learn a lot by creating those connections. We're talking about the mind, and so you kind of got to tap into that. And I also ask people to rate their hunger, because we have been conditioned to just eat. Yeah. Like in preschool, they just give you a snack, like it's really long standing. Come home from school, you get a snack. You work over to your grandma's and she rewards you with cookies, and so it's just like who we are in the society we are. So I ask people to tap into that. And then the next part of what we do, beyond the intake, beyond the physical, beyond the labs, is we do have to work with insurances. So even if you yourself do not take insurance, or work, in a group that does, it's imperative to figure, if you're going to offer a patient a solution, that it's a long-term solution. And so what did I do after the first visit is get on the phone with the insurance company and see what medications their plan covers, because some of these weight loss medications we're talking about are very effective, but they can be $1,500 a month. So I'm not even going to have that conversation with the patient. Yeah. So it's actually an important, thing to acknowledge, that we still have to realize that. And the other things that we'll do is we'll get you teed up with the other, we'll like look for the medical stuff. So do you have sleep apnea? Should you get a sleep test? Do we need to get more imaging? Did I hear something on your heart? Should we get an echo before I put you on a stimulant medication? Exercise tolerance, things like that. Mm-hmm. And then we come up with a plan. And that plan in most obesity medicine practices is multifaceted. So it's lifestyle, nutrition, and movement, and sleep, and stress, and then medical. So you kind of have to lay them all out. And as you can imagine, that's a lot to do. So most obesity medicine doctors see a lot of their patients. It's a lot more than a traditional internal medicine office. I would say that the frequency is more like psychiatrist, where you have to see someone more frequently at the beginning and really understand a rapport and help them through this phase. And then you can start to space things out. So that's it.
That's very, very interesting. I'm trying to look through some of these questions here. Someone asked about PCOS, and I know we had talked a little bit about that before we hit record.
Yeah.
The typical kind of I can't think of the right medical term for the appearance of a patient, but a typical PCOS patient is obese, if I remember correctly. Talk about how those go hand in hand.
I love this population. I love helping this population. This is what, I screen for on the medical side of things when someone comes into my office. Not all patients with PCOS suffer with overweight or obesity, but many do, because 70% of women with PCOS have insulin resistance. And I've mentioned that a lot, and there's a reason for it, because it is the primary driver of weight gain. And so in those patients, they often struggle with weight. Yeah. And this subset of patients, which is a lot, it's about 10% of women in the US, I would venture to say, have been pretty, just like my population of patients with obesity, they've been pretty marginalized and not really listened to, and their complaints aren't valid. They are, but they feel that way. And, our traditional medical system is you're in, you're out. There's nothing actually wrong with you right now, but you just don't feel great. I don't know. Here's a medication. So this is a very interesting, I think, emerging field that has crossover with mine and endocrine, and general women's health, that if someone's out there and listening, this is my passion, go for it. I think that there is an emerging movement where we need more doctors with their knowledge to help this subset of women who are becoming actually more empowered to come into the doctor saying, I need help with this. Mm-hmm. So I see that a lot. My treatment for women with PCOS for weight loss is often the same as it is just for any other patient with insulin resistance. So we really look at the macronutrients of a diet, and we do bring down carbohydrates, increase protein, and focus on the right sort of exercise. So exercise that doesn't spike your cortisol and exhaust you, but rather builds muscle and invigorates, and so we can kind of rebalance.
Yeah. Continuous glucose monitors are all the rage in the diabetes community. My dad was a type 1 diabetic, and so constantly checking his blood sugars and plugging in numbers on his insulin pump. Mm-hmm. And now we have this sticker basically that sits on the back of your arm. Mm-hmm. I spent a couple $100 a few months ago because I like data and technology, and I'm like, I want to see what these things are. And there are companies now that will sell it to people to just see how you're doing. Do you think with continuous glucose monitor technology becoming more prevalent and hopefully cheaper, that a normal kind of yearly visit to the doctor will include a continuous glucose monitor being mailed to you as part of your normal kind of workup?
I don't think it will, but I think it should. I think so. So medicine is great, but medicine is sometimes slow, and it does take about, I think I've seen the statistic, it takes about 17 years for something that we know to be true to be adopted widely into medicine.
That's it.
Yeah. So I
almost as slow as the CDC.
Yeah. So I think that I'm all for patient empowerment. And so I think a lot of these companies that are on the market, there is a disconnect now between okay, you found this, now what do you do with it? Yep. I think that what to do with it has to be multi-tiered. Like, I think the doctors that you take it to have to understand what it means. So I'm hopeful that this little field of mine, and endocrine too. Endocrinology is so needed right now, and is a wonderful field that's even more dynamic, than, and kind of has a broader approach than my field of obesity medicine. I'm hopeful that we start to learn more about this in the core fundamentals, because honestly, blood sugar affects everything. So if you're going to become a surgeon, you need to understand blood sugar. You need to know how to counsel your patients and care about it pre and post-op. What are you eating? Because you're going to do so much better if you can keep the blood sugar stable. Same thing in oncology. We know that ketogenic diets are very effective actually in the treatment and the post-treatment phase. So starting to understand that. So my hope is that we can bring this more into medical school, so that, in 10 years, all the doctors out in the world are like, sure, let me see your CGM readings.
Yeah. Well, even potentially there's big rumors out there for the next Apple Watch to have glucose monitoring built into it.
Really?
That would be phenomenal.
Okay.
So I'm excited. I love tech. I think tech can solve all of our problems eventually. We love to villainize food.
Yes.
You have Instagram influencers, TikTok influencers everywhere saying the keto diet is what's best. No, too much meat is bad for you. You have to be vegan. No, gluten is terrible for you, even if you're not celiac. No, dairy is bad for you.
Mm-hmm.
What's your stance on villainizing specific foods and food groups?
There is no one size fits all to health or to weight loss. And that's it. And I could have a huge brand if I just doubled down on hating one thing or another, but it's not good medicine. It's not the truth of it. So every single person is different and deserves a different approach. And what you culturally want to eat, what you can afford to eat, what is in your home, what you need to do in your day, that's going to influence a lot. And if you don't have celiac, I think when I went to medical school, if someone came in gluten, we'd be like, oh, what's wrong with them? They don't have celiac. They're nuts. I mean, that was kind of like the mantra, not that I was saying that, but it was kind of like passed down.
Yeah.
But if you feel better not eating gluten, why should I ever tell you to not eat gluten? Right.
Yeah.
And so it just doesn't make sense. So
yeah.
The key here is this concept of small atomic habits and sustainability. So it's what can you do every day, and then do it the next day, and then the next day. And the problem, and I love a ketogenic diet. I love a low carb diet for the right person and in the right support system. The problem is that if you try to overhaul your life and villainize one food group over the other, you tend to not be able to keep up those habits because they're not small and they're not buildable and they're not sustainable. So it really has to do with the individual. And I tell everyone who's listening, be a little careful if someone says I've got the solution, because weight and health is not that easy.
Shoot. You said something and I wanted to follow up, and then somebody had a good thing in the comments and I lost it. That's the worst. Let's start to take some questions. If you want to come on and ask a question with Dr. Sowa, go ahead and raise your hand. I'm going to accept this person here. I was so excited to ask a question, and then I lost it.
It's small habits.
Yeah. Atomic.
It'll come to you.
Anyway, yeah. That's all right. All right. So again, if you want to come on and ask a question, you can do so.
While we're waiting for the question, I just want to tell everyone who's listening that I think I have the best profession. I think I said this on your podcast before, but I have a very happy profession. And I chose this because I didn't do so well in not happy. I didn't like the getting to the disease place. I knew I needed to focus on prevention, and I didn't know what that looked like, because medicine really wasn't about prevention when I was training, and it was a lot of end of life and end of disease care. And so when I found this, I was like, oh, I think this is for me. And it really has been an absolutely fulfilling career because I get to help people reverse disease. And I don't think that there is any better feeling. And I had a patient last year. She told me that at the Thanksgiving table, she went around the table and she had to announce what she was thankful for. And she said me. And she said me because for the first time in 40 years of Thanksgivings, she felt like she wasn't going to overeat and be out of control. And she had lost 50 pounds and reversed all of this health. And she was still having great time sitting down at the Thanksgiving table. And so I don't know. I can't, I will go toe to toe with any doctor that says that they have the best profession. I love what I do.
Yeah. I remember what I was going to say. You were talking about kind of the profession, the healthcare profession, physicians. A patient comes in and says, I feel better when I don't eat gluten, but our tests, a biopsy shows that they don't have what we know as celiac. And I said those words specifically because what we know today, right? And I want every student watching this to understand that medicine is changing at an exponential rate. I was just reading a book the other day. I forget the name of it, but it was like 50 years ago or like 1960, it took 50 years for medical knowledge to double. And then in the 70s, it was 10 years. And now it's every 7 years, medical knowledge is doubling. And so the people who are coming in saying, I feel better not eating gluten, but don't have quote unquote celiac, might have this new thing called celiac 2 or whatever we call it tomorrow, because some researcher hidden away in a lab goes, oh, there's this other protein that we have just found that causes the same exact thing as celiac, and it expands our knowledge. And all we've been doing to this point is dismissing, and keep an open mind. That's why I always argue with my neurologist wife who says, oh, chronic Lyme doesn't exist. I'm like, says who? Right? Talk to the patients who are suffering post Lyme disease. And sure, maybe some of it is just mental health, but I guarantee you, at some point in the future, we're going to figure out the physiology of why these patients feel bad. Right. And we're in the middle of a pandemic now where we have long haul COVID that like nobody's going, oh, you don't have long haul COVID. That's not a thing. There's no COVID in your body anymore. Right. So why can't chronic Lyme be a thing?
I agree with you. And I have definitely changed and evolved. And I'm sure I was that person, even a couple years ago. But the more you talk to patients, and so I would recommend that is such great advice. Like, we know science, we believe in science, right? But sometimes you have to believe the patient and they'll tell you things. So check your ego, right? And it might not make sense, but not everything is going to be tied up in a neat little bow in medicine. And so that's such good advice. If everyone here takes that away as they progress in their career, you'll be so much better for it and you'll help so many more people because of it.
Yeah. Daniel, come on, say hello.
Hello, can you hear me? Okay, yeah, I just had one question. You mentioned the ketogenic diet a lot, and, I think there are like two sides. People say that, if you cut out carbs, it helps you lose weight, and, it's better just have high fat. And then some people say if you cut out carbs is like your main source of energy. It's bad because you have like a low blood sugar. And as you said, sometimes it's not sustainable because it's a really big change in how people eat. Do you think the ketogenic diet kind of like works for some people and works for others? Or do you think that it's something that, do you use it a lot in your practice?
I use it. I think sometimes ketogenic diets get a bad rap because we get so hyper focused on the high fat and the low carb, but there are varying gradations of what that can look like. And so probably in my practice, we go to more of a modified carbohydrate, low carbohydrate way of eating for the sustainable. But ketogenic diets have been proven over and over again in medicine to be kind of the gold standard way of eating for certain diseases. And in the disease of obesity and metabolic syndrome and insulin resistance, it can be curative without medications, which is remarkable. So some patients, when armed with that knowledge and like what's ahead of them or what they'll need to do, they'll say, I can do that. That sounds great. I can eat fish and chicken, and I can eat tofu for my protein source, and I can focus on whole veggies. And I can get some healthy fat sources in. No problem. Like, I don't have to give myself insulin. Great. And then you just have to, but for some others who don't like to cook and it's just not sustainable for them, you have to say, well, I'm not going to put you on something you have to start and stop every other day. So let's find something else that works. But it can be incredibly effective. I think that I think when you do it without having someone to coach you through it and to guide you through it and to get you through ups and downs with it, it can be dangerous because you'll start it and then you'll be like, oh, today wasn't a good day. I'll start tomorrow. And then you end up eating like high fat and high carbs and high processed foods all at once, because ketogenic can be super hyper palatable, meaning like overly delicious. And so you get used to that. And so that's the thing. You just have to, I honestly feel like it's almost therapeutic, where you really do need to be working with a nutritionist. You really do need to be working with a doctor. You really need to understand how to transition it to make it sustainable and to go with the ups and downs. Because it doesn't work most times out in the world. So people come to me all the time and say, I tried that. And then we'll try it again. And like, it worked this time. And I'm like, well, yes, because we know how to implement it, right? And it's kind of backed in science and backed in habit building.
Okay, thank you.
Thanks, Daniel. Shane.
Hey, so I had a question about like how patients come to you, and I was wondering, is like, do they get referrals from like their primary care? Do they like decide like, I have a problem, I'm not getting help from anybody else, so they seek you out? And then kind of as a tie into that, is there ever an instance where a patient comes in and says, I want to lose weight, let's look at this, and you find that there isn't like what you would call like a red flag, like a insulin resistance or metabolic syndrome or anything, and it's just like they just have extra fat,
Those are excellent questions. Really good. So people come to me through everything that you mentioned. So I get a lot of referrals, and I get a lot of patients then referring me, friends and family, and then people just seek me out. And it's often, most people who end up coming to a doctor for this have either a medical reason that they need to lose weight. Someone told them that, something else has developed and you need to lose weight, or they've tried and they failed again and they don't trust themselves again. And they're tired of this process. So this is a great question about who I see. So I actually do screen for most patients who come through my practice based on BMI. Or if not BMI, they need to demonstrate to me that they have something else metabolically, something else that's health-wise going on. I'm not in the business of making people skinny. I'm in the business of helping people get healthier. And there can be a fine line. I learned this early on in my career, and I think a lot of doctors in this field have to set limits about who they see and be very clear about what they're doing. I'm not helping people get into their skinny jeans, because that doesn't help anyone, right? And that precipitates this diet culture where we all need to look one size and be one size. If you are, have a BMI that is in the overweight range, but you are metabolically healthy, you're stable, it's who you are and how you're built, and you have tools to kind of keep that weight kind of semi-stable over the next 5, 10, 15 years, you're good. And I want to encourage you actually to stay there, as opposed to restrict and cycle and go do this yo-yo thing, because that is not healthy, actually. So that is why we kind of set these BMI markers. And although they're not exact, and although I might accept people with totally normal BMIs, but who have type 2 diabetes and they want to control it through diet, that's where I take it on a case-by-case basis. But most of the time, it does have to be with some, a BMI that is on the higher range, and we're doing this for health. And so I have some screening questionnaires, and I actually hop on the phone with patients before they come into the office, just to make sure that we're all on the same page.
Cool. Thank you.
Great question.
Thanks, Shane. And soon patients will find you, because you're going to have a podcast at some point. I've been talking to this woman forever about having a podcast. If you think she should have a podcast, leave a comment. Nari. Oh, you're muted still.
Oh, okay. I was just saying
There
it's
you go.
Nairi, but it doesn't sound like the way it's spelled.
All right.
I was just curious. I've noticed that there's basically reality shows about everything at this point, but we have shows now that are essentially about nothing more than being overweight. I mean, there was My 600-Pound Life for a while. There's more shows like that. And I was just curious about what you thought about that. I know that social media can have a really negative impact. And, I could see on the one hand that maybe these shows are promoting the idea that there's so much more to people beyond obviously what their weight is. But at the other hand, it seems to promote this really negative culture around being overweight. So I was just curious what your thoughts were, because, years ago we didn't have anything like that.
I can't speak to that show specifically. I've actually never seen it, if you can believe it. But shows like The Biggest Loser and shows that were probably, you guys are probably pretty young, but there were some like reality type shows that were all about becoming skinny and weight loss and like fixing how you looked with plastic surgery. And I think those are very,
is that the name of it?
Yes, exactly. Yeah. I think those are very exploitive. And they're unhealthy. I'm kind of proven it, right? So the most amazing thing that ever happened with reality TV and weight loss was the studies that came out of The Biggest Loser. And we were able to demonstrate that the way that they lost weight was totally ineffective. So that was fruitful, actually. It's taught us a lot about the set point of these hormones we were talking about earlier, leptin and ghrelin. I think humanizing people at any weight is good, right? We want to know, I think I just saw a storyline, someone on one of those shows was trying to get pregnant, right? There are real problems when we carry excess weight, but we're still human, right? Like we still want the same things. So I think they can be good if done right. I haven't seen that show specifically. I think television still has a role for helping people with excess weight or changes that need to be made in a healthy way and reversing it. So I haven't given up hope yet. Like I would love to be part of something like that where it's focused on the health side of things, but I don't know if that's sexy enough.
Thank you so much.
You're welcome.
Thanks for coming on. Last but not least, Javier.
Hello.
Hi there.
Hi.
Can you hear me right? Is it all good? Yeah, I just want to say, what are your thoughts in artificial sugars, things that are maybe like replacements to the real thing, right? Real thing, like maybe like diet soda, or an example, I really, really love sugar-free syrup. I pour it in everything. But like, you always hear things like, they're worse than the real thing, or it helps you gain that weight back, or what are your thoughts on it?
Yeah. It's person dependent. And so science shows this. So some people can take in artificial sugar and be fine. And it can actually help them keep a lower calorie kind of weight stable. Other people are hyper responders to it. And a CGM is actually a continuous glucose monitor is really helpful for that, to know if your blood sugar spikes after seeing it or not. So your brain, we try to out trick our body, but we're animals and we'll figure it out. If you eat something sweet, then your body is telling you that you just got a calorie excess and you need to either burn it off right away by running through the woods or to store it as fat for famine. And that's what artificial sugars can do. I am totally addicted to Diet Pepsi from medical school. That is like my number one regret. Don't touch the vending machines. Go get a source from somewhere else. Make your own coffee.
Seltzer water. I quit cold turkey my Diet Coke habit, and I realized I was addicted to the bubbles, not to the caffeine or anything else.
I have swapped it out. I've cut back, but something about medical school and the training, it killed me. Hate it.
That's
totally
funny.
Addicted. And actually it's very addicting too, right? So it's that reward center. We really rewire our brain by just pounding it with all this artificial sugar. It doesn't necessarily in a young, healthy body have the ill effects, but then you start to get addicted to it. And it has to be all that stuff that's packaged. Walk past it.
Yes.
Appreciate it. Thank you.
You're welcome.
What I've learned to do in our house when I go in periods where I can't control what I'm eating, or I think I can't control what I'm eating, and I was off sugar for like a year, and then the pandemic hit, and then I'm just like, give it to me. I can't handle anything else. Is marijuana lock boxes. So they sell cases that you can lock, and they have a little combination. And so we hide, like when I need to, I'll tell my wife, I'm like, you got to lock up the cookies. I can't control myself. But right now they're not locked up because I'm not craving them. I'm okay. But it works great. My 7-year-old knows how to open it up for dessert after dinner. So it's really, and it's a trick that I don't know where. Back in undergrad, when I was a personal trainer, and I had a patient who was on, I forget the exact medication he was on, but it caused him to sleepwalk and eat.
Yeah.
And so what they did was they just locked all the cabinets, and they couldn't get into it in the stage of awakeness that he was in. And so it's pretty funny.
That I've not heard that one. I might have to start using the marijuana lockbox trick.
Yes.
I'll be like, doctor, why do you know this?
Yes. I live in Colorado. It's okay. Well, awesome. Dr. Sowa, how can students find out more about you, sign up to get on a wait list for when your podcast comes out, all that good stuff?
You're so sweet. You have to walk me through it, and that's the only
I'm here
way
for
I'll
you.
do it. So you guys can find me on Instagram at Alexandra Sowa, MD. I've been there a little bit more frequently recently, because the one thing I did want to talk about before I left is that in addition to this practice, I've started a new company, and I've got it right here, a direct-to-consumer metabolic health kit company. So what I'm also really want to talk to students about is just taking your expertise and passion and doing something different with it, right? Ryan's a great example of that too. We don't all have to fit into the traditional box of what all of the years of education and training are. And they do something wonderful. They make you into well-vetted, well-trained doctor, but there is a world that you can kind of take those skills you loved before school and do something with them after. So you can follow along for that too. I think it's kind of inspiring. I wish I would have seen more doctors doing things like this.
Yeah. So next season of Shark Tank was just renewed for a 13th season. I think you should throw your hat in the ring.
Okay, that I will take you up on.
I love Shark Tank. So good.
Me too.
Are you a fan? Oh yeah, so nice.
I totally am.
Yeah.
It's great. I mean, it's great, and they give good advice, and that's so. If any of you, I mean, it's years away, guys, right? Like you have to put in the work, you have to do the things, and we all did too. But it's so exciting to have this power of extra knowledge and science and drive. And, it doesn't just have to look one way it doesn't have to look the same way for every person. So like Shark Tank and developing products, you could take this cool, interest in tech and science and passion and put it out into the world in a different way. So.
Yeah. Love it. We'll end there. Thank you so much for spending some time with us tonight. I took a ton of screenshots when I asked if you should have a podcast. The chat just went crazy with yes. Love it. So,
okay, guys, I'm counting on you. So I'm gonna launch, and you got to come over.
Yes, I'll follow up, and we'll figure out how to get you a podcast. Thank you, everyone, for coming.